Hello, and welcome to the UP Community Health Town Hall Series. I'm Kelly Cam, and tonight in September, we are going to be talking about UP healthcare related projects led by the Michigan Center for Rural Health. Many of you may be used to seeing Elise Bird, the director of Northern Michigan University Center for Rural Health here. She is out this evening, so you have me as the moderator instead. So our series is hosted by the Center for Rural Health at Northern Michigan University and organized in partnership with Michigan Tech University and the Department of Kinesiology and Integrative Physiology. Again, my name is Kelly Cam, and I'm an assistant professor at Michigan Tech. And I'm going to start us off by first giving you a little bit of background on rural health and why we're concerned about it, all of us up here in the UP, and then I'll introduce our panelists that we have tonight. So across the US, about 19% of our population is rural, and in Michigan, that's about 18%. And compared to urban areas, rural areas have higher rates of unhealthy behavior, less access to healthcare, less access to healthy foods. They're more food insecure. They have higher rates of premature death from the 5 top leading causes of death in the United States, which are heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke. And as many of you know, the interventions that are put in place in urban areas often don't work in rural areas. And that's why it's really important to have centers for rural health. So we have here tonight with us, so it's 4 of our members of the Center for Rural Health at the Michigan Center for Rural Health. We have John Barnes, who's the executive director, Andrea Abbas, who's the EMS program manager, Amanda St. Martin, who's the hospital programs manager, and Laura Mispellin, the social drivers of health manager. And I'm going to just dive right in and start with John. So welcome, John, and I'll let you go ahead and introduce yourself.
All right, thanks, Kelly, and thanks for this opportunity. Really appreciate this chance to discuss who we are on a broader platform in the Upper Peninsula. And we wish Elise was here, but next time, right? So I'm John Barnes. I'm the executive director of the Michigan Center for Rural Health. Just a little background. I've been the executive director at the center since February of 2000. Prior to that, I did start at the center in 1994, doing some special projects. And then prior to that, I really cut my teeth in healthcare as the director of program development at the federally qualified health center in Battle Creek. At that time, it was called the Family Health Center of Battle Creek. Now it's called Grace Health. We started off as North Avenue Women's Center, doing 100% Medicaid, OB, and GYN services. We got another Kellogg Foundation grant. We put in pediatrics. And then finally, we've got a third Kellogg Foundation grant. And that put in the full lifespan of adult family practice, and OB. We wrote the FQHC grant to the feds. It was turned down the first time. We tried again the second time. We got it. And so that's where I really cut my teeth on understanding what a safety net provider is, and have made the transition into rural health, and have lived in rural health and have a second home in Port Austin, Michigan, at the tip of the thumb, 640 people. So I get it. So that's my background. So stop talking about me. So who is the Michigan Center for Rural Health? We are the state office of rural health. Every state in the nation has a state office of rural health. So there's 50 state offices. 37 of them are inside state government, hence the term state office of rural health. Another 10 are actual university based, like my colleagues at Penn State University or Oregon State University or University of Wisconsin-Madison. And then there are 3 nonprofit types, and that's Michigan, South Carolina, and Colorado. And truthfully speaking, if we talk to our federal partners, they really like the nonprofit variety because as you will learn in this next hour, that it really allows a state office to spread its wings and get into more than just like the core service programs that I'll describe. So we were established along with all of the other state offices by congressional act back in 1991. funded. So we are federally funded and also receive a state appropriation. So that's our match money. Nonprofit organization. We live at Michigan State University. So when you contact us, you'll notice that our email address is at msu.edu. That's because the College of Osteopathic Medicine at MSU lets us live there for free. Free is good. 98% of all of our grant money goes into programs and services. 2% in management in general. You can't touch that. That's impossible to touch, and that only happens out of the good graces of Michigan State and the dean of COM. So that's where we live, is in West Fee Hall on the second floor, sharing space with family and community medicine. So I do have a board of directors. We have a board of directors. And if you go to our website, you'll see it's made up of a variety of trade associations, state departments, and state elected officials. So for instance, I do have a board member from the Michigan Nurses Association that's vacant right now, MSMS, MOA, Michigan Association of Local Public Health. That'd be Nectar Russia from LMAS up in your neck of the woods there. The Michigan Primary Care Association, the Michigan Department of Health and Human Services, Health Policy and Planning, MDHHS EMS Division. Then we have the Office of the Governor, a State House member, and a State Senate member. And then, of course, our landlord, the Dean Andy Amalfitano, is on our board too. So I have 12 board members. What else? We have 14 staff members. We've grown quite exponentially in the last 3 years. We probably have one of the state's best grant writers on staff, Crystal Barter, who's Director of Programs and Services. She's been hitting the ball really hard, and we've had a number of new HRSA, federal grants, Health Resource Service Administration grants, come into our shop in the last 3 years. Actually, it's 6 of them to be specific. So we have 14 staff members now, 10 who would call the East Lansing campus their office, coming in once a week. We have 3 up in Gaylord with our Rural Community Opioid Response Planning grants that we have up there, a project called the Northern Michigan Opioid Response Consortium. And then we have another person up there, Kelly, in the Marquette, Jim Yates. He's managing our Veteran Outreach Grant. He's a retired Marine, and his job is to go out and find veterans and their families who are outside of the primary care stream and also behavioral health, and get them in and make sure they can use their benefits. All the veterans, they don't all use their benefits, and they deserve their benefits. So it's his job to find them and get them into the stream. So that's a little background of who we are. 14 staff, 3 different sites, and our budget's about, I'm going to make a presentation tomorrow morning to our board of directors. It's about $7 million. And we're managing 21 different grant programs and services. So moving into that's our kind of like our corporate structure of who we are. So that's the boring stuff. So here's the good stuff. With the 21 different grant programs, all state offices have 3 core programs. The State Office of Rural Health Program, the Medicare Rural Flexibility Program, which people will call the Critical Access Hospital Program for short, you guys have 16 hospitals in the UP, and I think 12 of them are critical access hospitals. I might be off on that one. And then the final program that all 50 state offices share is a Small Hospital Improvement Grant Program. So state office, CAH, and SHIP. So what are they for us? For us, the state office group program is our cornerstone program. And off of that builds everything else that we do. It's our smallest grant program, but it's our most important one because all the other 20 programs that we're doing flow off of it. And probably the 3 key programs that come off it are education and workforce. So Renee in our office is our education manager, and we're considered, the Center for All is considered a affiliate of MSU. And so that really allows us to knock on the doors of the various departments and colleges across the campus and find faculty who want to partner with us and teach for free. And so just about every Wednesday at noon, Renee has a grand round, and the subject could be on geriatric education, pain management, oral health issues. And so it crosses a wide spectrum of different disciplines. And she's busy. I think last year she gave out free 2,500 contact hours. And that's a lot of free education, so people don't have to travel far to get their education. As an example, a social worker needs 36 hours of contact hours, CEUs, every 3 years. Through our office working with Renee, you can probably get 12 to 14 of those. You don't have to, and it's free, so your hospital doesn't have to pay for it. We also have another project called Project Echo. That's a little different. Grand rounds are more didactic. Project Echo is more physician-based, and it's coming from the field. And we use Dr. Peter Gulick out of the infectious disease department. He's pretty well known across the United States for his work. And so he provides education on a monthly basis on infectious disease. Physicians will send in a case study, and then he provides an education topic around how to solve that. So that way a patient can stay with a family practice doctor, we hope, and not have to travel from, I don't know, Ontonagon over to Marquette. You can maybe take care of the things of your family practice doctor in Onto. So there's another one. And then we have Access to Care Manager. That's Paige, and her job is to basically get up every day and recruit primary care providers into our hospitals and clinics. Now, we've had a little shift in that because with the pandemic, we found that where'd all the workers go, right? They seem to all be gone. They're not coming back. And so, we're talking to hospital CEOs, and they need more than just primary care providers. What they're looking for now is rad techs, farm techs, medical assistants. And so she's helped working with Kevin Kalchek over at the Sioux, and Hunter and Andy over at Newberry and Schoolcraft, and developing an MA pipeline program. So people are coming on board, they're getting trained, working on what they're doing. And then when they graduate, they get a pay bump up. So if anyone is out there interested in becoming an MA, give us a call, send us an email. We can set you up with one of those 3 hospitals and get you in the MA program. So that's what we do with the state office. Critical Access Hospital, Andrea and Laura and Amanda will be talking about pieces of that program. I'll just also mention 2 other things. We do some financial and operational improvement with that grant. We'll do some lean work, which is having Jeff Nagy, who's our quality improvement advisor, go into a hospital and set up a program where he'll assist them in like the ED department in taking the amount of time, reduce the amount of time that it takes to push a patient through with the proper quality of care. That can happen also in the pharmacy and in the lab and those things. So we're looking to push down costs, increase quality. And then lastly, there's an innovation section in the Critical Access Hospital program where we're bringing together with Jill Osterly, who's our Director of Provider Solutions, to manage certified rural health clinics, bring them together and manage their quality, benchmark it, post it, drive up the quality, reduce the cost. And I will brag about Jill here. We're the only state in the nation to have a certified rural health clinic quality network. And so across the nation, if someone has a question about it, it's 1-800-JILL as they're calling her up. And then the final program that we all share across the nation is a small hospital improvement program. And that's a grant program to hospitals that allow for financial review, checking their charge master, working on pay for performance and value-based programming. That's the 3 core. Now for us, I just want to mention before, we hand it over to Andrea, we do have 4 other programs that come out of East Lansing that touch the Upper Peninsula. The first one, and Laura knows this one quite well, we worked with the state of Michigan Health and Human Services and got a CDC grant that allowed us to fund all 23 rural local public health districts and put in community health workers. And so we've been able to find additional funding, and community health workers are a big deal, and Laura might be touching on that. But that's one grant that I think there's 5 or 6 local public health districts across the Upper Peninsula. They all got a good chunk of money to stand up these community health workers in their health offices and also in their schools. Second one is a rural community opioid response program. We have been very fortunate. Crystal has been an exceptional writer on funding 6 consecutive years of RCORE, and one of them happens to be the PsychoStim, RCORE PsychoStim, and that has 6 grants going up I-75, and then also the 3 counties from the bridge up to the Sioux, where we're working with the hospital. So it'd be My Michigan Sioux. We're working with Helen, Newberry Joy, that'd be Hunter Shop, and then St. Ignace, Mackinac Straits Health System, Karen Cheeseman. So we're working with them to decrease the amount of PsychoStim use in across the I-75 with the data points. That's where most of this is all occurring. The last 2, I spoke briefly about iReach, which is the veterans program with Jim Yates. He's doing a fantastic job. I sometimes think there's more than just one of Jim by the amount of travel and places that he visits, going into American Legions and VFWs and hospitals and clinics. And, one of the most important things that we found working with Jim and some of the researchers is the most important question that the front desk person can ask any patient. You want to ask this to any patient is, have you served? And if they say yes, then you find out if they're getting their benefits. If they say no, then you sit them down with the social worker and you find out why aren't they getting their benefits. That's the most important question to ask any person the first time they're coming in to see the nurse practitioner, or the PA, or the doctor. Have you served? And we're making sure that's happening across all clinic sites across the Upper Peninsula. And right now the numbers are bearing out that we're having more veterans getting in and getting their benefits. So kudos to Jim. It's a great program. And then lastly, and this is, I'm not going to take anything away from Laura, because she's going to, or not Laura, but Amanda, because she's going to talk about remote patient monitoring. But that's a really important project that she's going to discuss that that touches 2 communities in the Upper Peninsula. Very important. So I'm gonna stop right there. I don't know if there's people out there that have questions, or it's in the chat box or whatnot, but I certainly don't want to use up. I think I've used more time than I should have. I'm sorry, guys.
In the interest of time, we'll save the questions for a little bit later. I do want to put a plug in that as part of the National Organization for the State Offices of Rural Health is that on November 16th is National Rural Health Day. And the Center for Rural Health at Northern Michigan will be hosting an essays competition for seniors in the high school seniors in the UP who are interested in going into healthcare careers. And there'll be more information coming soon on that, but just to put a plug out there, this year's theme is Celebrate the Power of Rural, and the state offices have quite a bit of, and the national system has all kinds of swag and stuff you can put on social media and everything. To keep things moving along, our next person is Andrea Abbas, who's going to be speaking about the EMS project. So welcome, Andrea, and take it away.
Well, thank you, Kelly. So my name is Andrea Abbas. I am the EMS programs manager here at the center. A little bit about my background. I'll just follow suit with John. I always have to give a clip note version, otherwise I feel like it's just going to go on and on. But I started my career aspiring to go to medical school. Started teaching collegiate level biology classes while working part-time as a paramedic. Once I got into my paramedic education during college, I started to really question my path to med school. I took that entrance exam, the MCAT for med school a couple times, got a great score, and then was working in the field at that time full-time, and became really curious about the business model behind EMS and started asking a lot of questions. My curiosity then led me into my first leadership role. And since then, I fulfilled many quality and compliance, road supervisor, EMS director, EMS innovation coordinator. I've worked for large corporates, small rural agencies, suburban, urban, rural. And I landed at the center at the state office, and now I oversee some larger grant projects. So with that, I am currently managing 3 grants. The first grant that I'd like to talk about is the Flex EMS Supplemental. That grant is providing funds for us to improve rural EMS data quality reporting throughout Michigan. So we have 11 agencies enrolled in that program. Many of them are dispersed across the state, but a majority of them are in northern Michigan and the Upper Peninsula. And we are working to improve data quality reporting for each agency. So we're doing great work there, discovering some issues when it comes to moving data just in and out of the state and national portals, and then helping each agency get to the root of those issues and fix them. That in turn will, of course, affect the quality of patient care that we deliver on a state and national level. So that's one exciting grant project that we're focused on through the center. The next one is called the UP WIN grant. That grant provided funding not only for community health worker training and education and programming, which I don't oversee. That would actually be Elise Burr's program. But I am taking lead on the community paramedicine aspect of it. So we received funds that will allow us to fund paramedic education in the UP. We currently have 26 aspiring paramedics enrolled in UP Health Systems paramedic program. And then from there, we're going to take those paramedics and the paramedics in the community interested and train them as community integrated paramedics. And they will be launching their first, or really the Upper Peninsula's first pilot program in community integrated paramedicine. So that's a little bit about the UP WIN grant. And then the last grant that I am currently managing is of the EMS Workforce Grant, where we are now in round 2. We are receiving funds that allow us to provide initial paramedic education scholarship funds to aspiring paramedics across the state. And we've done something really cool there where we've given preference to those serving rural communities, but also veterans, single parents, those of female background, and oh boy, there was one other. Single parents, veterans. There's one I'm missing, but it's racial and ethnic diverse backgrounds. Thank you. So that's the last program. And then on top of that, I have a robust education program where we are able to offer CE credits to paramedics across Michigan. So each month we offer some kind of CE opportunity, and we also have really developed a reputation for delivering top-notch EMS leadership education. So each year we provide a leadership academy that the students go through. And not only is this an educational opportunity for them, but we view it as supporting sustainability because we teach these leaders all types of skills that then help them lead well. And when you lead well, you're more sustainable. So, that is a little bit about what I do through the center. I will turn it over to you, Kelly. Thank you.
I have just one question to start off here. So I know I have many students who also work as EMS within Michigan Tech and some that even work outside in our communities. And it sounds like a lot of them are volunteers or working on various different systems. And so I was wondering if you can talk a little bit about the challenges of EMS in a rural area that's very different from an urban area, whether
Yeah.
it's related to this volunteer status or other challenges they have.
Yeah, so there is a mix, and you're right. There's a lot of volunteer, paid on call type of systems. Then there are non-volunteer systems, large corporate systems, very small mom and pop paid systems. So the challenges that accompany a rural system versus like an urban or suburban system really come back to, well, I'd like to start with geography. So, you might be in the mountains, you might be traversing terrain in ambulances. And so that geography can be a challenge when it comes to being in a really rural system. And when I say geography, I also mean distance. So the distance you have to a not just a critical access hospital, but a larger system hospital that's a trauma center, a stroke center, a cardiac center. But really, the other thing that comes to mind right away is the challenges with budget. So, each time we set our garbage out and the garbage man comes and picks up the garbage, right? We are taxpayers and we pay into that. And when we look at police and fire, most systems are a tax-based system. With emergency medical services in many communities, that's not the case. And so what ends up happening is we get this diverse payment system depending on the community. So every system is really supported locally. So in a rural system, it could be the yearly fundraiser, fish fry. It could be a small millage that they get from their community to run the system, or it could be nothing, and they could be just dependent on donations and volume. And the issue with that is an annual operating budget for an EMS system as of 2023 ranges from 1.04 million to 2.25 million. So oftentimes community members don't realize to start and sustain a system, that is the kind of funding that's needed. The other thing that is a difference between rural and suburban is the way EMS systems are sustained and paid. So what I mean by that is EMS is filed under the National Highway and Traffic Safety Administration. It is seen as a transport system, and it's evolved to present day as healthcare. We do lots of healthcare, but we're paid by insurance companies based on mileage, and then we get, like a flat rate. I won't get into rates because then I might surprise a lot of people, right? But with that, a low volume operating cost can cost per call $41,500. And this would be a system that, for example, runs under 1,000 calls. So this is what the research is showing. That $41,500 per transport is the cost of readiness. So it's the ambulance that costs $350,000. It's the monitor that costs $35,000. It's the stretcher that costs $45,000, et cetera. Now, in a higher volume system, so we're looking at above 50,000 calls or so, you're looking at roughly a cost of $1,020 per response. So you can see the difference in the cost of transport and the cost of readiness went way down. And the reason for that is you need volume based on the payment model today. So going back to the initial question of what is the difference between rural and suburban, one of the stark differences is depending on how you're funded locally, you are at a severe disadvantage because in rural systems, you're not going to get the volume you're going to get in a suburban system. So taking the demand of that community and then the way payment is set up, and it can be challenging. A couple other things really quickly to consider just to really thoroughly answer your question, and I'm going to stop myself because I could go on. I'm kind of a nerd, if you haven't noticed, is the distribution of EMS education sites, right? So there are education sites typically located near suburban and urban areas because, again, education systems need to draw students, to draw revenue, et cetera, et cetera. You have more people in general. And in rural areas, it tends to be geographically challenging to get to programs. So this can be also a hindrance to provide the education site should then have the providers in the community. And then the population and payer mix, again, going back to if there's more people, there's more runs, there's more people carrying insurance. Typically, there typically tends to be more jobs in those communities. And so in a rural, beautiful, serene setting, you're just going to have less people. And so those are some of the challenges that I think are really at the top of my mind when I think of a rural system versus a suburban or urban or more populated area.
Thank you. For anybody of our listeners who are joining us, we are talking tonight about UP healthcare related projects that are led by the Michigan Center for Rural Health, otherwise known as the State Office for Rural Health. I certainly for myself was a little confused on that, so I appreciate John clarifying that. We're going to move on to our next speaker is Amanda St. Martin. She is the Hospital Programs Manager. So welcome. You're muted.
Thank you. So again, my name is Amanda St. Martin, and I am the Hospital Programs Manager for the Michigan Center for Rural Health. I've been with them approximately 5 or 6 months now, but my background is in practice management operations, and so that was where I spent the first 19 years of my career in healthcare, was in hospital-based practices. So I wanted to start out with saying that I am very fortunate to work with a great group of individuals who make up the Michigan Critical Access Quality Network, and their impact reaches across the state of Michigan. I just wanted to take a couple minutes to just kind of highlight that group. They were established in 2001, and they're comprised of quality leaders from Michigan's 37 critical access hospitals across the state of Michigan. 11 of those hospitals are located in the Upper Peninsula. They too are, they're governed by an executive committee, and 4 of the members that sit on that are also from UP hospitals. The network's been broken down into 3 strategy groups who have specific focuses on improving healthcare and the quality of healthcare in critical access hospitals by making them safer, by reducing harm and cause in the delivery of healthcare through data management and also analytics. And they do this by meeting quarterly where best practices are shared. They share their quality data, benchmarking. They're very transparent with each other. And then they work to improve those quality measures for patient healthcare within the critical access hospitals. I want to say that the Michigan Critical Access Hospital Network is seen as a national leader in quality reporting and performance. This has been demonstrated by an involvement in the Health Resources and Services Administration, as well as the Medicare Beneficiary Quality Improvement Program. So since the inception of the MICA-QN, Michigan Critical Access hospitals have consistently ranked in the top 10 states for the United States for quality reporting and performance. I would say if there's anyone listening who would like to get involved with the MICA-QN, it would be wonderful if they reached out to their critical access quality department and to see how that they can engage in their hospital's quality program. Another area that John was talking about and mentioning was Michigan Center for Rural Health is remote patient monitoring program. In December of 2022, the Michigan Center for Rural Health, in collaboration with Higi, who is a Motive Care company, through a grant from the Michigan Health Endowment Fund, launched an 18-month remote patient monitoring program in 3 critical access hospitals across northern Michigan: Schoolcraft Memorial Hospital, Helen Newberry Joy Hospital, both on the Upper Peninsula, as well as Mackenzie Health System in the Thumb. We understand that rural health care organizations face resource constraints, making adopting innovative technologies very challenging. So the RPM pilot offers a solution addressing unmet needs in the digital healthcare in the rural setting, ultimately benefiting patients and the healthcare organizations alike. The pilot was aims to alleviate the burden of healthcare professionals by providing continuous remote patient monitoring interventions from Higgy Care Everyday Nurse Care Managers that ensures patients actively participate in their own healthcare journey. The pilot is focusing on high-risk patients who are diagnosed with hypertension, diabetes, and congestive heart failure. Each patient is assigned a dedicated care manager to monitor their chronic care conditions using remote medical devices, which include blood pressure cuffs, blood glucose monitors, and weight scales. The devices are cellular enabled, meaning that the patients only need to insert the batteries that are included in the packaging once the devices arrive to their homes. There's no app, no Bluetooth or Wi-Fi is needed for connectivity. And by offering this tailored care, regular support, patient satisfaction is expected to rise as patients experience a reduction in unnecessary emergency department visits and hospital admissions, improving medication adherence and in care plan adherence, increasing the percentage of patients whose diabetes and hypertension becomes well controlled, and also reducing the short-term and long-term overall cost and care, overall cost of care through improved health outcomes and a higher quality of care. Since its inception in July of 2023, and by inception, I mean the amount of time that we started in December of 2022 to July, that was our ramp up and build up time, because it takes a little bit of time to implement the process into the facility. We have had, our UP hospitals have had 18 total patients enrolled into the program, and we have an additional 20 patients who are in the process of being enrolled. Our goal is to have anywhere between 100 and 150 patients per facility before the end of our program, which is in July of 2024. So in addition to enrolling a patient into RPM, participants are offered a program assistance if they're desired through Higgy's partnership with Advocacia Solutions. Advocacia is a benefit and financial assistance enrollment solution for hospitals, and they aid their patients by identifying financial assistance and programs that include Medicaid, CHIP, SNAP, as well as programs through the Health Exchange Marketplace. And this can be also local to them, so they can help them find local resources for help as well. Sorry. So the expectation then would be to, of course, address social determinants of health issues, improve medication adherence, increase access to care, reduce healthcare disparities, leading to the better health outcomes and lower healthcare costs for patients. Right now, MCRH, Higgy, as well as our participating critical access hospitals are identifying the lessons learned and best practices and scalable solutions to create a playbook for expanding the initiative statewide. The playbook's going to encompass solutions for both the healthcare providers as well as the patients. We want to ensure that the digital health in the rural setting becomes replicable as a model for success in other hospitals within the state of Michigan. The pilot, I believe, is not just about improving healthcare; it's about transforming how healthcare is delivered in rural communities, making that quality of care accessible to all, regardless of your location.
Great. That's all fascinating work that's being done there. So you mentioned that you're aiming for 150 patients at each facility. If someone is interested in participating in the remote patient monitoring project, how would they find out or get enrolled? What do they need to do?
So we're still actively enrolling patients. So that's a great question in the pilot. So if you are a patient at one of the pilot organizations, or you know someone who is, and they have a Medicare Part B and have been diagnosed with either hypertension, diabetes, or congestive heart failure, they are encouraged to reach out about the RPM pilot. And the Higgy Everyday Care team has graciously provided me with a telephone number that patients or family loved ones can reach out to. And I will give that number to you now. It is 855-560-0094. And interested patients can also reach out to their primary care doctor for additional information about the program.
Great. Thank you so much. We're going to move along here and keep, we'll have some questions, I think, for everybody at the end, but I want to make sure that we have time for everybody to get through, because there's so many really interesting programs and really helpful programs that are you guys are running here. So our next speaker is Laura Mispellin. She is the Social Drivers of Health Manager, and I'm going to turn that over to Laura to explain more about her programs.
Thank you. I appreciate it. Hi, everybody. As Kelly mentioned, my name is Laura Mispellin, and I am the Social Drivers of Health Manager at the Michigan Center for Rural Health. I was lucky enough to get started to work at the center just over a year ago, with my first career being a dental hygienist. So I worked in that profession for over 12 years, along with with COVID and just kind of trying to decide where my next path was going to lead. I decided to go back to school at Ferris State, and I got my Master's of Healthcare Administration through an internship. I was lucky enough to find MCRH, and really I was excited about that kind of population health space. I thought it was kind of an interesting, as I was embedded within the healthcare, but also kind of that public health space. And then as I got to work over the summer, a grant opportunity came about, and I like to say it was a lot of luck as well too. But then I was able to work there, and I've been there for about a year since. So before I dive into my position, I wanted to spend just a moment kind of going over what the social drivers of health are. I think it is an area that is starting to be discussed more, and it really is within a topic that is at the forefront. But I think there is still kind of some lack of understanding with it. And so I just wanted to spend just a moment with that. I also am going to spend a moment just explaining why we use the terminology drivers instead of determinants. With any new terminology, it's like, oh my gosh, now we have another term that we need to learn and it's changed. But I promise we do not use it just to cause confusion, that there is actually a reason behind it. So the social drivers of health are the non-medical factors that influence our health outcomes. So when we really look at health outcomes, we're looking at the length of life, but also that quality of life. So these are the conditions in the environments where we are born, where we live, learn, work, and play. They affect our overall health and well-being, and they truly just impact our quality of life. So as we look at barriers such as food access, safe housing, and reliable transportation, these are all of the factors that can impact an individual's ability to attain their highest level of health. As far as why we use drivers instead of determinants, again, I know it is one of those things that we start using a term and it shifts, but I promise there is a reason as to why we do use it. I will say for us, it is an important shift that we like to recognize, and we really do try to be intentional of why we do. So we feel that in using the determinants of health, it could unintentionally indicate a sense of finality and suggest that someone has less control over their health and well-being. So although these factors, the social drivers of health, affect our health outcomes and they drive them, we strongly believe that they should not be a determining factor. I also think it's important to note that these social drivers of health are issues that also reside on a policy level as well. So in using the drivers, we're ensuring that policymakers and decision makers are also held accountable, and the blame isn't just being placed on the person themselves. We strongly believe at MCRH that an individual's health should not be predetermined, especially by their zip code. So that's kind of just a bit of background on why we chose to use the drivers. So now I get to brag about my role a bit and all the work that we're doing in the SDOH space. Like I said, this position started back in late August. So really at MCRH, we're continuing to grow and really understand that upstream approaches that are needed to ensure that rural communities thrive. I will say what I truly have enjoyed about this first year at working at MCRH is that we've been able to connect with organizations that are already doing incredible work in the SDOH space. And we have been able to collaborate and see how we can promote the work that is already being done. As John mentioned and Amanda too, our work at MCRH is really embedded within rural communities, especially kind of in that critical access space, and then also within the rural health clinics as well. But a lot of the work that we have traditionally done is really embedded within the four walls of the hospitals. So this has really allowed us to extend our reach and ensure, that these rural stakeholders continue to be a part of this discussion. Next, I wanted to spend just a few moments discussing the work that we're doing, as John kind of had alluded to, with the Michigan Department of Health and Human Services. It is a lengthy name, so kind of from here on out, I am just going to say MDHHS, but I did just want to preface what it stood for. So through our work with MDHHS, we have been creating a rural health equity plan, which is a supplement to their SDOH strategy, which, if you aren't familiar, it focuses on housing stability, food security, and health equity. If you have not had an opportunity to dive in this work that they're doing, I would encourage you to check out their site, because they really have put a lot of time into making sure that SDOH are addressed throughout the entire state, but also making sure that everyone is at the table with this work. So which is why we have been brought on board, is to really provide that rural lens and make sure that, individuals that reside in rural, that work in rural with the SDOH work are part of this talk. So our plan will provide a rural lens and ultimately identify a list of rural specific recommendations that align with their current work. So the recommendations will identify opportunities for improvement. It'll assess the current rural landscape and engage with rural stakeholders. We started this work last October, which is wild to think that we have been doing it so long, because it went by so fast. But really, we started by understanding the context and kind of that rural perspective that's within the SDOH work. We wanted to assess the data and also determine the rural stakeholder engagement in putting together the initial plan. This helped us to understand the gaps in rural engagement within their SDOH strategy. We also found it really important to put together an advisory group, which is really at the heart of the work that we're doing. We wanted to make sure that this advisory group truly represented rural. And I will say, and I might be a little bit biased, but it is a great group that has really led us into this amazing space. We have also been working to understand and review data for rural areas. Sometimes when we look at data, that rural urban divide isn't quite highlighted like it should be. And so we're really trying to be thoughtful on the data that we bring together within this report as well. Before I wrap up, I just wanted to say too, throughout kind of this last month, we've started to host focus groups, which was really to assess the current state of Michigan assistance. So this is still part of our rural health plan, but just a different component where we wanted to connect with both organizations that assist communities in trying to apply for state assistance and resources. And then also we wanted to connect with people that actually use it to better understand their experience as well. As we all know, what works in urban communities does not always work in rural. And so that is really what drives this work and this plan. And we want to make sure that it goes alongside of the work that's already being done, but really to provide that rural lens. So far we have hosted a few of the listening sessions in the Upper Peninsula, and we virtually have been able to connect with organizations within that area. We do, however, have a survey that we would love if anybody works for an organization, that does help individuals provide assistance, and we would love your insight. So I would be happy to disperse that, and Elise will make sure that she has that as well too. I will do a little plug for MCRH. We do send out a monthly newsletter, which it will be highlighted for this month. So if you are not signed up for our newsletter, please do so. Again, I might be a little biased, but we do really try to make sure that all the information in there is relevant to rural, and that, the information gets out to you. But check that out. I will also say that we are hosting our virtual focus groups in the upcoming week. So with the focus groups, we're trying to connect with those that actually utilize state assistance. So if you would like to participate, or you're willing to connect or help us connect with individuals that are willing to join, please feel free to reach out as well too. Within these, we will provide a $25 Visa card because we want to make sure that we compensate you for your time. I wanted to just kind of end with saying that this is a completely new role for us. And really, we want to learn and grow in this space. So if you work in the SDOH space and we haven't connected, please reach out. I want to hear about all the incredible work that's being done in the area that you live. And hopefully, there is a way for us to promote your work or collaborate. But just besides, the amazing work that's being done, we really want to understand the barriers that exist within your areas as well too. So I think one of our big things is that when you are in a rural area, especially in the UP, the West Side is very, very different than the East Side. And so we want to make sure that we're bringing all the voices together, and that we understand what you all need as well. Last plug I will put in, please check out our website because it has so much information, and it's a great way to connect with us too. So it's mcrh.msu.edu. So that's it. Thank you.
Thank you very much, Laura. Is there anything that you can really briefly, I mean, I realize as an epidemiologist with ongoing research, it's really hard to do anything with preliminary data. We're presenting some next week at a conference, but is there anything you can say that's about any of the focus groups that you have completed up here in the UP?
Yeah, so we haven't, so far we've only done like that organizational lens yet. We haven't connected with those end users. So that's the one I'm always very excited about as well. But from the organizational lens, I will say that, especially for the My Bridges platform, individuals often benefit from what I hear for having someone walk them through the process. So it's one of those things that it can sometimes be a tricky thing to walk through on your own. And sometimes it's hard to get that person that can kind of meet you where you're at to walk you through it. So that I would say is an area that has been brought up a few times. No surprise to anyone. If they need transportation to actually provide the documentation, that is a hard thing that has been discussed as well too. And then kind of the big elephant is that the broadband. A lot of these platforms are switching to being done online, and they have so many resources to help individuals walk through it online. But if they can't get online, then they're not able to access that. So I would say kind of as a whole, those are the ones that tend to rise to the top so far.
Great, thank you very much. We actually have a question that came in from one of our listeners, and I'd like to, I think, pose this to John. So she mentions that you're based on a medical model, but are there any potential for mental health inclusions in some of the programs that you do? Or are you mostly working on physical health? And certainly, mental health is a big part of the issues that we have across the nation.
Well, I'm glad the listener brought that up because that's an oversight on my part to have not mentioned that we are doing some work on the behavioral health side. We do have a grant, a 3-year grant to increase the number of behavioral health specialists and access to care in the 27 counties at our NWORK project that I mentioned, the OUD SUD project, our core work. So we're working with Munson Medical facilities, which is on like one side of I-75 and 127, and then my Michigan facilities, and basically from M55 up, they basically have those areas as their service areas. And we're working with both systems to increase access to care to behavioral health and also increase the number of behavioral health specialists. So thanks to that listener who brought that up. That was an oversight. Yeah, so we try and spread across all that we can on all disciplines.
Great.
And I will add this, if anyone is out there, who would be interested or knows of someone or maybe someone in their family who would be interested in becoming an EMT or a medical assistant or a community health worker, just Google Michigan Center for Rural Health and you'll find all of our email addresses and ask us how help me get into that field. Put me into contact with the people that I need to be in contact with to get on that career path. We'll get on that email as quick as you can imagine.
And I'm sure if those listeners can find Elise easier at Northern Michigan, I'm sure Elise will put you guys in contact with the right people as well. And that actually brings up a question that I personally had. We have just a couple minutes left. I think this is probably another question for John. So I know certainly I was learning that you guys are also the state office. So that was certainly for myself a learning curve. But can you quickly describe the relationship between Northern Michigan Center for Rural Health and your organization so that that's kind of clear to everybody as well as
Sure.
myself?
Yeah. Again, that's a really good question. So it was 3 years ago, the provost at NMU approached me, and at that point in time, for anyone who remembers, there was a trustee at NMU, Jim Haveman. Jim was the director of the Michigan Department of Community Health, and then the name was changed to Department of Health and Human Services. And he held that job twice, once when Governor Engler was governor, and the second time through when Governor Snyder was here. And so I've known Jim a very long time. He's a true advocate for rural health. He's on the board. He's talking to the board and says, we really need to have, we being NMU, really need to have a greater outreach across the peninsula on healthcare. We need to meld together our academic structure with improving the lives of people and with their health. And so the provost called me, and come to find out, when I was at the FQHC in Battle Creek, so was she, as she went through her residency program as a certified nurse midwife. And so it was like old times again. But besides all that, we came up with a model that we agreed upon where Elise would have her role at Northern Michigan Center for Rural Health, and we would support her as much as we could. In fact, she's invited to every one of our Monday morning staff meetings and listens to our report outs, and she tells us what's going on. She's managing a grant that we wrote with Andrea. Andrea is doing the paramedic side, increase the number of paramedics and community paramedics, and Elise's job is to increase the number of community health workers, and that's our Rural Public Health Workforce Grant. So
Great. I'm going to have to interrupt for just a moment here because we're just about out of time. So
okay.
We can talk about that a little bit later on. For everybody that's been listening, thank you so much. Thank you to our listeners, and we'll have Elise back on next month to move on with our next one. So thank you guys all very much, and have a wonderful weekend.